Welcome to everyone to our webinar on COVID-19 reflections and the path to recovery.
So now I would like to introduce Dr. Fred Resnic. Dr. Fred Resnic is the chairman of Cardiovascular Medicine at Lahey Hospital and Medical Center. He's a professor of medicine at Tufts University School of Medicine. Fred received his undergraduate degree from Duke University in electric engineering and his medical degree from Mount Sinai, New York. And then he completed his internal medicine as well as fellowship in cardiovascular medicine and interventional cardiology at the Brigham and Women's Hospital in Boston. Additionally, Fred holds a Master's of Science degree with concentration in medical informatics from MIT. Fred has contributed to research with the NIH and FDA and has published more than 100 articles and book chapters, including the New England Journal of Medicine, JAMA, and Journal of the American College of Cardiology. And he was the former American College of Cardiology, Massachusetts chapter, and currently serves on the NCDR Oversight Committee. Please welcome Fred Resnic.
Hi, just making sure you can hear me. That's good. I see nodding. First of all, thank you to YL, Sue, the organizers, the coordinators of this important meeting. It's really been very educational, fascinating to hear Thomas Friedman's perspective. I'm glad I didn't follow him, as well as the Minister of Health and Dr. Craig Ciottone. So I'm going to speak in the next short while about our experience in rapidly expanding the critical care capacity in response to the COVID emergency. And just so you can choose to leave in 2 minutes if you'd like, I'm just going to tell you what I'm going to say so you know. So the first thing is that planning is challenging, and it's really a continuous process. And what I'm going to speak about is the planning in critical care. And I think some statistics may help. The critical care surge that we experienced in the spring of this past year, by the nature and the organization of healthcare in Massachusetts, United States, roughly 95% of patients whom we treat in critical care units are intubated, and they are deathly ill. And so most of the patients who are on even high flow oxygen, non-invasive oxygen strategies are not treated in the critical care units. They're treated in step-down floor beds. So we're really talking about the sick patients, and even the volume of sick patients was enormous. What we learned is that, it's all about people and communication, empathy, being calm and reinforcing the mission. The need to run into the fire, as Thomas Friedman mentioned, is really critical to maintaining staff morale, which is critical to providing care. Another lesson was that everybody, physicians, advanced practitioners, meaning nurse practitioners, physician assistants, nurses, everybody can be mobilized and deployed into an ICU setting, even with limited experience. We also learned that it is very overwhelming and stressful, and it requires really pre-scheduled recovery time. Don't believe staff members who say they're feeling fine after a few days of working in an ICU. They're not. And we learned some important lessons. Avoid open critical care units, that is, those without separation, true rooms for each of the patients. Avoid geographic separation of surge spaces, and always believe in your staff, and they will believe in themselves, and they will step up and do an amazing job. So our hospital, for the folks who are not that familiar with the region in Eastern Massachusetts. So first of all, I'm an interventional cardiologist. I'm not a critical care provider, although we provide critical care in coronary care unit settings. I was an engineer, as YL mentioned, and I'm the chairman of cardiovascular medicine at Lahey. Where I work is Lahey Hospital, which is a 320-bed hospital. It's relatively small. with 52 licensed critical care beds, which is typical for a tertiary care hospital, that sort of ratio in the United States. And what we were facing in March 2020 is that it was clear that Massachusetts was going to be part of what was an epicenter of the initial surge of COVID-19. So we needed to get ready very quickly. Now, for our international colleagues on the call today, this is obviously the United States. Now, this is looking backwards at the United States from the very end of August, where the dark red maroon color is the density of infections of COVID-19. And you can see that the Northeast here encircled right where Massachusetts sits was really an epicenter, the true epicenter being New York City. There were a lot of what appear to be very well-performing predictive models that are available for every region of the world. One that is commonly used and cited is from the University of Washington. And this is the prediction at the beginning of April for what the critical care needs would be for Massachusetts. And again, I'm focusing on critical care, but we had to get ready for floor bed surge, just hospitalized patients, ED capacity, et cetera. And so the projected peak was that we needed almost 1,900 ICU beds. And this was a problem because in Massachusetts, there were only 1,500 ICU beds. And that was after a couple of weeks of seeing the experience in other parts of the Northeast, specifically New York City and northern New Jersey. And so this was already dialed downward. On the graph on the right here is actually what the State Department of Public Health was rapidly asking the hospitals to do, and that was to add 1,200 additional ICU beds across the state, which is an enormous number, and even adding 1,000 extra regular floor beds in temporary hospitals. So the hospital, or rather the state, was asking all of the hospitals to add ICU beds because our baseline was 1,500, but we had a plan for 2,700, and this green area here is the uncertainty factor. And this is all that the state could imagine us getting to in terms of the number of basically ventilators and staff that we had. So we had to move as a state from here, this dashed dark line to the red line, and every hospital needed to contribute. Now, I'm going to show this as sort of just a mile marker over the next few minutes of what the experience was from March until the end of the surge at the beginning of June. And the first case was actually experienced in Massachusetts. It was one of the first cases on the East Coast. But then there was a long quiescent period where we saw what was happening on the West Coast, specifically in Oregon and Washington State. But there was a rapid increase in our case volume at the beginning of March. And this is what the actual volume was, again, taken from the University of Washington Institute for Healthcare modeling is taken. So we had this period of exponential growth. At the bottom, the state instituted a mandatory shutdown, only absolutely essential activities. All the hospitals had to shut down any sort of elective care. And the state became sort of a ghost town. And we didn't really have systematic testing throughout the state until later in March, when we had already begun to hit the plateau phase. And what's being plotted at the bottom is the daily utilization, the daily increase in the number of ICU patients through these months. We hit this sort of critical care peak census just before May. And why it looks delayed is because the average length of stay in an ICU for these new patients, shown at the bottom, coming into the ICU, was around 30 days. So patients coming into the ICU would stay for 30 days, and a lot would be dying in the first 30 days. There were a lot of patients who were staying 60 days, 90 days in the ICU. And finally, just before the start of June, the critical care capacity fell below that 1,500 that we were talking about. So for these 2.5 months, the state was in a crisis situation. And it wasn't just the peak was sustained. So now we're going to think a little bit about what happened to Lahey Hospital. And again, my involvement was that our critical care lead providers from a variety of specialties were in the war already. They were already fighting the war at the end of March. And I, as sort of the last remaining critical care leader in the hospital who wasn't yet pulled into the frontline battles, was asked to now organize our surge teams. So we established an incident command structure and started planning for our expanded capacity by basically seeking how we could double and triple capacity. And so this was our first mission, was to just get organized. And so we initiated this incident command. We had to think about the 3 S's: space, staff, and stuff. Space, the places to put patients; staff, who is going to care for them; stuff, everything we need from PPE to ventilators to the disposables, the tubing, etc. And we actually sought to increase critical care capacity about 3-fold. And then we realized very quickly that there was a critical shortage of PPE throughout the United States at this time, which created incredible stress for all. Unfortunately, at the same time, while we were starting to see the surge in Massachusetts, we were also watching the news and seeing unbelievable images from, where many of us grew up. I grew up in the New York metropolitan area, and I went to medical school in New York and worked at some of these hospitals. But these are the images, of just crisis staffing, and then the temporary morgue trucks, bodies being unable to be buried. It was unbelievable while we were planning. Not only that, but we were planning what to do if we ran out of ventilators. And emotionally, in the United States, this was a very difficult thing for our healthcare system to sort of grapple with. What do you do when you now are seeing that patients are staying on ventilators for 4 weeks, and the next patient comes in and you don't have one? How do you take care of the next patient? Do you actually terminally extubate the patients whom you think might not make it, so you can save the one that comes in? So we had to, in the context of all this anxiety and frankly terror, we had to keep our staff calm. We had to be empathetic and focus on this shared mission of looking forward to what we knew we were coming for us, which was the battle ahead. So then we had to go ahead and expand our units, and we had to bring in these teams of non-critical care trained individuals to start launching these satellite critical care beds. So we developed so many different space and staffing models, and it was changing literally every day. So we also had to identify every potential physician, advanced practice provider, and nurse that could be capable of contributing to this critical care environment. And we had to have communication with both the people who were willing to help, but there were a lot of people who were scared, hesitant, and even a few who fundamentally could not emotionally join. And the reality was that, whatever plans you had, they were changing day to day, hour to hour. So we had to keep our staff calm and focused on the shared mission. And we had to be thoughtful about how to communicate, because when you change plans over and over and over when you're communicating, that only adds to the anxiety. So there was a lot more discussions happening than communication, but the communication was very regular out to the soon to be deployed staff. And I think Wael mentioned that I was an engineer in the past, so and somewhat of a sort of a data intensive data scientist. So I developed this model, and we had all different ones. This was just for critical care. This is actually a schematic of our hospital. You can't see it as a hospital because maybe you're not an engineer, but these are each wing of the hospital. This is the east side, the central part of the hospital, the west side. These are the floors of the hospital. And each one of these noted areas are places where we could have put critical care patients. And if we had to, we would put them there. So we were starting with already a bunch of COVID patients who were intubated in our medical intensive care unit on the 2nd floor. But we had to figure out how to get from 52 intensive care unit beds up to about 180 intensive care unit beds. That was the max theoretical capacity that we were asked to be able to plan for. And so we had different ways of running this model of putting these COVID patients elsewhere. But then what did we do with the non-COVID patients? And we tried not to mix them, but we had to keep the right lead doctors and nurses taking care of the neurocritical care patients who didn't have COVID while still caring for the COVID patients. And finally, we were able to come up with a model where we had COVID critical care patients all over the hospital, 179 beds planned for with teams ready to go. But we had to do this sort of incrementally because, of course, the tidal wave doesn't come all at once. We did learn a lesson, by the way, which is that the idea of having separated satellite critical care units really turned out to not be effective. Another one was we did end up using a very large, open, and well structured critical care environment, which is the post-surgical recovery room. But that is physically an open unit, and it required all staff to maintain full PPE with N95 masks and full coverage throughout their shifts, and that is untenable throughout the course of a day. All right, so the next thing we did was we were communicating with our teams as they're starting to roll out unit by unit by unit, listening and getting feedback. And we really needed to narrow the focus because it is overwhelming to take physicians, nurses, and others who have not yet, who have spent years not in an intensive care unit, and now you're going to throw them into an intensive care unit with a highly communicable disease and patients who are so incredibly sick. And I have to mention that having served in the critical care unit, as did YL, as did Sue Stempek, who's on the line multiple days, the patients, the respiratory failure of these patients was one thing, but there is a phenomena of sort of a cytokine storm that would hit at about 8 to 10 days after their medical deterioration. That was literally unbelievable. There was very little that you could do except sort of ride the rapids of trying to care for these patients. I also was involved in all 3 of the patients that we put on ECMO during these cases, twice as the implanting physician and twice as a caring physician. So we had to reduce and narrow the focus because this was overwhelming. So we created 4 teams. One was an intubation team where anesthesiologists would actually rove from unit to unit as needed to intubate patients or to adjust the endotracheal tubes. We had a nursing-led proning team that would come and really implement, which is a ARDS sort of advanced therapy, and it works tremendously in many patients in improving their oxygenation. But we don't try to teach all of the nurses how to safely flip these patients into the prone position. We had a line team for placing central lines and arterial lines, dialysis catheter lines, and then we had a communication team that was basically those physicians, nurses, and others who could not participate because of their own high risk for contracting the disease. They were deployed to basically be calling patients' families. Remember, visitors were prohibited at this time. And so we were all using these different teams to just help the new surge providers focus on just the bedside care of the patients. So we built these teams from 27 different clinical divisions. I think we trained 140 different physicians who had not been in the critical care environment in a long time. We assigned them to different units, designated roles in the units, and we had this sort of pyramid structure, which started out with those 4 support teams I just mentioned, the intubation team, the proning team, et cetera. And then we said, okay, now we're going to have these surge providers, no fewer than 3 at a time on during a day, taking care of up to 12 to 18 patients. We always partnered them with an experienced critical care attending. And then above that, we had regional critical care attendings who were really expert pulmonary critical care, who would be supporting those experienced critical care attendings in making advising decisions regarding who should be prone, who should be considered for ECMO, who should be having more advanced therapies. We developed a really robust training program. Sue Stempek was absolutely instrumental in this, where we had online and in-person ICU basic didactic sessions. I remember one session called ventilator buttonology, How do you change the settings of a ventilator and just focus on the basic things: oxygenation, ventilation rate, changing PEEP and pressure levels. We had weekly clinical care case review sessions because people were so wholly invested in this. It was what they were thinking about 24/7, that they wanted to learn more. They wanted to understand what the infectious disease doctors were learning literally every week. Hydroxychloroquine might work. Hydroxychloroquine definitely doesn't work. How do you get a patient to get convalescent plasma? Can we get any remdesivir? When should we start it? But we also learned that the imbalance of deployment amongst the teams and the duration of deployment for those who went to their units early led to a lot of dissatisfaction, because this is exhausting. So we launched, and we did those things that I mentioned, and we ended up with only 100, at one time, only 110 critical care patients, 98 of which were intubated. And we had about 40 providers going to different roles every day. And so just in terms of what happened at Lahey, so here's this surge of the state that occurred. And this is what happened at Lahey with our critical care capacity. And the dashed line here is that 52 beds. This was our max capacity. So basically in red is shown the non-COVID patients. You would see we were trying to not work for, on those conditions that would lead to critical care for non-COVID, as we saw COVID in blue skyrocketing, so that the combined rate of COVID and non-COVID was exceeding 110 here in a few days in mid-April, when I happened to be on one of the service teams, which was really busy. Of course, what was also going on in the hospital was the surge of the non-critical care patient population. And so I just now, I've taken away the non-COVID ICU patients. So this is the blue of the COVID ICU patients, these incredibly sick patients for which we were consuming all this PPE, all this space, and all these providers. But guess what? We also had to take care of all these non-critical COVID patients, also with specialized teams, with specialized nurses, with isolation, PPE, et cetera. And that led to virtually every provider, every clinician in the hospital pitching in at some level to care for what was an unbelievable spike in the experience of COVID treatment. And then it ended, and it ended slowly. I remember the plateau lasting for week after week after week in the ICUs. But then we had to start thinking, how do you carefully, thoughtfully start closing units? And of course, we started by closing those units that were so hard to maintain, the geographically isolated ones, the ones that were open units. And then really importantly, and again, I think my partnership with Sue, Sue Stempek, who's leading some of this discussion, was to really understand what we did right and what didn't go well, because we thought this is going to happen again. And now we're living it, right? We're living it now. So one thing is, we did learn what happened, and we ended up caring for over 200 critically ill patients, up to 110 at one time. And the plot on the right shows us just towards the end of the surge, when we had taken care of 164 patients in their ICUs, 66 had died, and at this moment in time, 14 remained in the ICU in these very prolonged length of stay. But we think about it, 58 at this time went home or had been extubated to the floor. Another 8 had been extubated but still required critical care. But this sort of ICU success was kind of remarkable, because the overall mortality was only 44% of patients who were basically all ventilated with critical illness. And we were really proud of this, because the data out of New York was in the 70s and 80% mortality. And I think we're seeing this throughout the world, that we are getting better at caring for these patients. But what was really interesting is that there was no difference between these sort of geographic surge units that were managed by non-critical care providers with the oversight of an experienced critical care leader and a regional intensivist. They had the same outcomes as the core experienced critical care units. And so we kind of view this as our success. So now we have to start planning for surge number 2, which is started. It looks different today than it did in April, but we need to think about what worked well. And so what worked well, this pyramid structure, having experienced senior attending critical care docs, taking care of newly trained unit teams. We learned that teams that kind of worked together over longer periods of time became cohesive and supportive and trusted each other. We certainly learned that these roving support teams, intubation, line, proning, they were enormously helpful. I think I learned that the communication liaison program was really greatly appreciated by families, but we need to make it more time efficient for the lead doctors. And that these weekly education and town hall discussions where people would just sort of vent about what was working and not working and why they're scared or what, it was so reassuring to them to not feel abandoned that even though we were saying the same thing over and over, it was really important. And what didn't work? Well, you can't trust providers to actually say that they need time off. It needs to be scheduled in, lots of time off. And now we're just doing that as part of our next surge plan. We also need to make things even, that everybody who's going to do this just does the same role, has the same types of shifts, day and night. Again, avoid geographic isolation, avoid the open units, and avoid scrambling. So now when we're scheduling an entire backup schedule as part of the plan. And people will know that they're on the backup schedule, and their bosses will know that they're on the backup schedule, and that they will be pulled if necessary. Final thought, living through the surge. So there's some very nice sort of anecdotes from the military and from, let's say, athletics. So the first is no battle plan survives the first contact with the enemy, which had been attributed to General Dwight Eisenhower, but in fact was a German general back in the 1800s. And it's true, as soon as something happened, your plan basically changed. And then better stated is by Mike Tyson, the former heavyweight champion of the world. Everybody has a plan until they get punched in the mouth, and that is true as well. So our plans have to change, and we have to change dynamically. And so we had to be honest and communicate with everybody that there were things that we did right, but things that we did wrong. And we also had to recognize that healthcare professionals are human, and they really have a lot of anxiety about the unknown, their own personal risk. It's compounded by the fact that they're human and they're living their usual lives, and they're concerned about their family and their friends and their family that are living in a different state and experiencing different things. But in the end, I think we also really learned something, which is that these frightened, anxious healthcare providers who hadn't worked in critical care in years became incredibly proud of what they did and what the organization was able to do to rise to the challenge. And then a really unexpected benefit was something that I think has persisted, which is this sense of community amongst the healthcare professionals. And I think it's true at every hospital that lived through a surge, is that you learn how valuable every one of your colleagues really is. And that has been durable. Maybe it has, a half-life, like many things, but I think it has helped us to be prepared for the next surge. So with that, I just want to thank the organizers, and then in the right, I want to thank the frontline care providers, including the nurses, the doctors, the resident fellow trainees, the advanced practice providers, the respiratory therapists, the transport staff, the radiology technologists, phlebotomists, unit coordinators, nursing care assistants, and every other member of the team. And they rushed into this unknowable crisis in March to help care for the community, and it made us all very proud. So with that, thank you very much.
Thank you, Fred, so much for this outstanding presentation. Of course, Fred was also a frontline provider himself, although we as a department, we try among us to push him out because he's a leader. We want the leader to be safe, but he insisted, and he was also working as a leader and a frontline provider by himself in the ICU unit. Thank you, Fred. I would maybe give one question if Sue has one, and then we'll move on to the next speaker.
Yeah, so Fred, one question that arose is, how do we explain the difference between Lahey's data and that of the Jordanian experience that we've heard a little bit about in earlier talks?
So, I mean, I think I'm not familiar with the challenges of caring for patients in the Jordan critical care units, but I do think we have to be honest and realize that Lahey is a tertiary hospital, a single tertiary hospital in Massachusetts, which is an area that has tremendous resources of healthcare. The number of doctors, nurses, and advanced practitioners that we were able to deploy because of the resources, effectively the wealth of the community here in Eastern Massachusetts, it's an unfair comparison to those parts of the world that did not have 3 doctors, 3 support doctors, a lead doctor, sometimes an extra advanced practitioner during every day to take care of only 12 to 16 patients. So we had literally a ratio, and the nurses, same thing. We had most nursing staff was taking care of at most 2 or 3 patients at a time. And I think that's a huge difference. The turnaround time for our labs, the access possibly to certain medications, the ability for us to do, I mean, we had access, right, to angiotensin II, an intravenous, extraordinarily expensive drug for that patient who had cytokine storm. I really think it made a big difference. And I think that we're starting to see that throughout the world, there is a reduced mortality by learning some lessons from everywhere. But I think it is much harder in resource-constrained environments. So I don't know the details, but I know that we have more resources than many places in the United States, and certainly that means many places in the world.
Thank you, Fred. Thank you so much.